Alright, now let's take a look at heart development, or heart morphogenesis, and in particular, cardiac looping. The heart begins as a simple tube, lined with endothelial cells and myoblasts, and is the first functional organ within the embryo, and it starts beating at about the 4th week. When looking at the primitive heart, the top part here actually comes out of the screen, towards you, and a little to the right, while the inferior part actually goes into the screen, and a little bit to the left. This continues until the bottom part of the heart tube actually ends up near the top. And as you can see, the primitive atria here is currently on the bottom, and we know in the adult version of the heart, this is actually toward the top. Thankfully, test examiners are not going to ask you in which direction cardiac looping occurs, but rather, they would expect you to look at a CT image, like this one, or maybe even like this one, and ask you what's going on. Do you notice anything different about these two images? Well, the organs here are actually in the opposite location that you would expect. In the CT of the thorax, you'll notice how the heart is sitting to the right, which is called dextrocardia, and in the abdominal CT, you'll see how the spleen and the liver are switched. And can you think of a disease state that might actually cause this? Great, Cardiovascular syndrome. And do you remember the pathophysiology behind this? There you go, it's due to a defect in the microtubule protein called left to right dynin. Without proper functioning microtubules, cilia cannot function in regular cellular motility, fluid transport, and signal transduction pathways. This particular dynin is called left to right dynin because it is critical in the positioning of organs from the left to the right side of the body. Sinus inversus is a Latin term that means inverted sides, and this can be seen in left to right dynin defects. In the image here, you'll notice that A is actually normal, with the right lung having 3 lobes, the liver being under the right side of the hemidiaphragm, and the spleen being under the left. Image B is an example of situs inversus. Here you'll notice that the left lung has 3 lobes, and that the liver is under the left side of the hemidiaphragm. And you'll notice that the spleen is under the right side of the hemidiaphragm. Here, the big things to remember are that left to right dynin defects can lead to situs inversus, and this can be seen in Cardiovascular syndrome or primary ciliary dyskinesia. Alright, now let's talk about septation of the atrial chambers. The name of the structures involved in the development of the atria will help us understand these events. We'll start off by using this diagram. So first off, a segment of tissue will begin to grow down from the top of the atria. This is called the septum primum. This first septum, or septum primum, begins to grow downward toward the endocardial cushion, which is sitting in the atrioventricular canal. Now, do you remember which syndrome commonly results in AV canal defects? There you go, you've got it, Down syndrome. Now that the septum primum has begun to form, it has formed a smaller communication between the left and right atrium. This is called the foramen primum, or first opening. And just to review, foramen and ostium both mean hole, so don't let the interchange of these words throw you off. As the septum primum expands toward the endocardial cushion, the upper portion begins to degenerate. This forms the foramen secundum, or the second hole. Eventually, the septum primum will reach the endocardial cushion and will fuse. As the septum primum is fusing with the endocardial cushion and the atrioventricular canal, a second septum is starting to develop. This second septum is called the septum secundum. The septum secundum develops just to the right of the septum primum and grows from both the superior portion of the primitive atria as well as the endocardial cushion, as you can see here. Unlike the septum primum, the septum secundum does not grow all the way down. Notice this in image 4. Here you see the septum secundum hanging to the right of the septum primum. The way the septum secundum sits over the foramen secundum forms the foramen ovale. The remaining portion of the septum primum, which is attached to the endocardial cushion, will form a valve over the foramen ovale. So just to review this process in whole, the septum primum grows down toward the endocardial cushion, and this creates the foramen primum. In the second image here, you can see that the septum primum continues to grow downward toward the endocardial cushion while the superior portion degenerates. As the superior portion degenerates, the foramen secundum is formed. In the third image, we see that the septum primum has fused with the endocardial cushion, and the foramen secundum is maintaining the right to left shunt within the atria. Also within this third image, you see the septum secundum, which begins to grow down from the right side of the septum primum. You can then move on to the fourth image, where you can continue to follow the growth of the septum secundum as it forms the foramen ovale over the foramen secundum. So why exactly does all this happen? Well, it's actually to create a pressure valve. The remnant of the septum primum, as you can see here, will act as a unidirectional pressure valve covering the foramen ovale to prevent blood from flowing from the left atrium to the right atrium. Any increase in pressure within the left atrium will push the valve shut and prevent any undesired flow from left to right. In this scenario, there is no problem with flow from right to left because we actually want oxygenated blood to bypass the pulmonary circulation and go straight into the left atrium through the foramen ovale in the fetus. And what do you think happens after birth? Well, after birth, the pulmonary circulation opens and the pressure on the right side of the heart drops drastically. After this drop, the left-sided atrial pressures will be higher than the right-sided atrial pressures. This increased pressure on the left side of the heart will constantly push the septum primum against the septum secundum, eventually fibrosing the surfaces together and obliterating the opening. This obliterated foramen ovale is now called the fossa ovalis. So what happens if this fusion does not occur and you don't get a fossa ovalis? Well, this leads to the development of a patent foramen ovale, as you can see here. This is an abnormal communication after birth between the right and the left atrium. And in this case, it permits deoxygenated blood from the right atrium to bypass the lungs and mix with oxygenated blood emptying in from the pulmonary veins into the left atrium. So how are you going to be tested on this? Well, you may see a young male or female with a known hypercoagulable state, for example factor V Leiden, who presents after a long car ride or plane trip with left-sided hemiparesis. You get an MRI and you see an ischemic stroke. So what's the cause of this patient's CVA? Well, in this case, anytime you see a long plane flight or car ride, combined with a coagulopathy, you need to be thinking about a DVT. The fact that the patient is suffering neurologic symptoms means that somehow the embolus crossed from the venous circulation to the arterial circulation and finally lodged in one of the arteries of the brain. So how could this happen? Well, it could travel from the venous to arterial side via a PFO or atrial septal defect. And where would the embolism go if it did not cross over into the left side of the heart? Well, in this case, it would get trapped in one of the small branches of the pulmonary arteries, resulting in a pulmonary embolism. This would create a red or hemorrhagic infarct, as you can see here. Red infarcts occur in organs with two types of circulation, such as the lungs, the liver, and the brain. The lungs receive blood via the pulmonary and bronchial arteries as well as veins. Once again, even though this is a fairly rare clinical scenario, examiners love testing this kind of concept to incorporate some form of embryology along with other clinical pathology, such as a DVT. Alright, now we're going to talk about septation of the ventricular chambers. The two developing ventricles have a medial muscular wall which forms the muscular intraventricular septum. As the intraventricular septum forms, it creates a communication between the two ventricles, and this is called the intraventricular foramen. So how do you think we're going to close off this communication between the two ventricles? Well, the endocardial cushion as well as the aorticopulmonary septum send down a membranous sheet of tissue. This membranous sheet is the membranous intraventricular septum, and this portion closes the intraventricular foramen. So all in all, the intraventricular septum has a muscular and a membranous part. That means that you can have two types of ventricular septal defects, a muscular one or a membranous one. Ventricular septal defects are the most common congenital cardiac defect, and a membranous defect is more common than a muscular defect. To help me remember this, I like to think that the muscle is stronger than the membrane, so it's more common to have a VSD through the membranous septum. So if you were to have a VSD, what type of shunt would this create? You've got it. After birth, you would see a left to right shunt across the ventricular septal defect. Alright, let's try a flash quiz. The blank forms to close the intraventricular foramen and separate the two ventricles. There you go, the membranous intraventricular septum. Alright, next up we're going to talk about outflow tract formation. To do this, I'll be using the following diagram. As our muscular intraventricular septum grows, it eventually fuses with the aorticopulmonary septum. So where exactly did this aorticopulmonary septum come from? Well, that's what we're going to be talking about here, and here's a diagram of the developing heart. This lower region is the bulbus cordis, and up top, you'll see the truncus arteriosus. Within this developing heart tube, there is endocardial tissue that begins to grow toward midline. First off, we're going to draw some cross sections through the truncal and bulbar areas here so we can see the development of this aorticopulmonary septum. The endocardial cells of these areas will grow toward midline, and this occurs in a twisting motion all the way from the top of the truncus arteriosus to the bottom of the bulbus cordis. This creates a new septum that divides the trunk into two pathways, the aortic pathway and the pulmonary pathway, as you can see here. So who is exactly responsible for this coordination? Well, it's neural crest cells. Neural crest cells interact with proliferations of endocardial cells in the area of the bulbus cordis and the truncus arteriosus. This results in two outgrowths of tissue called the truncal and bulbar ridges, which grow together and fuse to form the aorticopulmonary septum. The 180-degree spiral movement of the aorticopulmonary septum as it descends causes the truncus arteriosus to rotate. During this process, a few things can go wrong. First off, you can have failure of the septum to rotate properly, and this can result in transposition of the great vessels, as you can see here. In this case, the aorta will be connected to the right ventricle, and the pulmonary arteries will be connected to the left ventricle. This results in two closed-loop circulations. So how does an infant survive when the pulmonary and systemic circulations are completely separate? Well, they need to have multiple abnormal communications. These include VSDs, ASDs, and PFOs. And this is so oxygenated and deoxygenated blood can mix. Another abnormality you may see with aorticopulmonary septum development is displacement of the septum anteriorly and laterally. This results in tetralogy of Fallot, and you can see this here. This poor placement leads to a very stenotic opening of the pulmonary outflow tract, as well as several other abnormalities. Do you think you can name them? Well, number one would be pulmonary outflow tract obstruction, and you can see that here. Another thing that occurs due to the anterior and lateral displacement of the aorticopulmonary septum is you get a VSD, and you can see this here. The stenotic opening of the pulmonary outflow tract results in very high pressures for the right ventricle, and this causes right ventricular hypertrophy, and this is the third thing that can be seen with tetralogy of Fallot. The fourth thing that can be seen in tetralogy of Fallot is an overriding aorta, and this is because the aortic outflow tract is sitting directly over the VSD, and you can see this here. Another thing to mention for tetralogy of Fallot is that the right ventricular hypertrophy, which is secondary to the pulmonary outflow obstruction, leads to increased pressures within the right ventricle. These increased pressures lead to a right to left shunt through the VSD that we mentioned earlier. This results in deoxygenated blood being pumped into systemic circulation, and this is one reason for early surgical correction with tetralogy of Fallot. And last but not least, patients with tetralogy of Fallot have right ventricular hypertrophy, as we mentioned earlier. And this RVH leads to a fairly classic chest x-ray. So what do you think the heart would look like on chest x-ray in a patient with tetralogy of Fallot or severe RVH? You've got it, a boot. The heart will look like a boot. The last thing that we need to talk about that can go wrong with the aorticopulmonary septum is complete failure of the aorticopulmonary septum to form within the truncus arteriosus. So what do you think this would create? You've got it. One large truncus arteriosus draining both the right and left ventricle. Here you can see an associated image where the outflow tract comes together to form one large trunk which drains both the left and the right ventricle. Of note, this is commonly associated with a VSD, and you can see this here. Alright, so next up we're going to talk about valve development. The aortic and pulmonary valves are formed from proliferations of endocardial cushions within the ventricular outflow tracts. These start out as large bulges into the canal, called valve swellings, and eventually break down via apoptosis to form the valve cusp, as you can see here. These valve cusps are just thin sheets of connective tissue and will serve as the valve leaflets later on. The atrioventricular valves, which are the mitral and tricuspid valves, form from tissue which is surrounding the atrioventricular canal. This tissue fuses with the endocardial cushion tissue to form the atrioventricular valves. The semilunar valves, or aortic and pulmonary valves, form from endocardial cushion tissue within the aortic and pulmonary outflow tracts. If a valve fails to form, then we have an atretic valve. This literally means without perforation, because there is no separation between the atrioventricular canal. One commonly tested form of this is tricuspid atresia, and you can see an example of this here. This atretic tricuspid valve does not separate the right atria and the right ventricle. This means blood is unable to flow from the right atria to the right ventricle, and this results in a weak, tiny, rudimentary right ventricle, as you can see here. Due to the rudimentary right ventricle, you end up developing one large left ventricle, and you can see this here. With tricuspid atresia, you must have both an ASD and a VSD for viability. This is because blood entering the right atrium passes through the ASD into the left atrium, which empties blood into the left ventricle. There, the blood will go through the VSD and enter the pulmonary circulation to obtain oxygen. Blood will also go out of the left ventricle through the aortic valve into systemic circulation. If this condition is found prior to birth, prostaglandins are commonly given to keep the ductus arteriosus open to increase blood to the pulmonary circulation. So what if instead of the valve being atretic, or not forming correctly, the valve actually forms, but it's displaced? Do you know what you'd get? You've got it, Epstein's anomaly. And you can see an example of this here. In this case, you get displaced tricuspid valve leaflets that are tethered down to the myocardium of the right ventricle. This results in an atrialized right ventricle because it appears that the right atrium extends into the right ventricle. And you can see this here. Epstein's anomaly has one very high yield point for the boards, and it has to do with the in utero exposure. And do you know which exposure this is? You've got it, lithium exposure. Once again, this is very high yield, so make sure you know it for test day.